So moving on, transference and countertransference, often an unconscious process and not recognized until too late. So transference and countertransference, I got into a little bit. They are definitely their own separate thing going on here, but they also can relate to the boundaries area. Back to the example I gave, that if we are enabling and taking on the role of a codependent person, and it relates to rescuing and failure report and setting limits, then it's in a boundary area. But it can also go further just to be its own thing, transference, countertransference. And I would first say transference, I don't want to get too far in myself. Let me define it first. Is a phenomenon within psychotherapy in which the feelings of a person had about their parents is one example, not just parents again, could be spouse, everything. I gave the example of the kid, are unconsciously redirected or transferred to the present situation. It usually concerns feelings from a primary relationship during childhood. At times, this transference can be considered inappropriate. Transference was first described by Sigmund Freud, the founder of psychoanalysis, who considered it an important part of psychoanalytical treatment. And with that said, I do want to say transference can have its place in therapy. It can be beneficial, but the trick is we have to see it and we have to be comfortable working within it. And we have to be mindful not to counter transfer, but instead be like, hey, I noticed this thing. It seems like maybe some stuff from another area of your life's coming in. Let's talk about and unpack where that's coming from. That's when it can have therapeutic value. Goes back to the example with me with the kid. I don't think he transferred intentionally on me some behaviors of minding my son, but I'm sure there are behaviors that any father, 18-year-old might encounter. Do you understand what I'm saying there? So me just being that kind of middle-aged man with that, there's just that possibility, me counter transferring and treating him like one of my kids. That's when it becomes a problem. You guys get that difference? I wish you could respond because I hope you do. I do have some videos that I think will clarify, unpack more what I said, and also hopefully if I missed something, might do a better job than me.
Transference is one of the most important and intriguing concepts in psychology. It refers to the unconscious redirection of feelings from a person in one's past to another in the present. Knowing about the word and its meaning is a key to trying to become a slightly more mature and less dangerous person to be around. At the heart of the theory of transference is the idea that our expectations of what other people are like is to an overwhelming extent dictated by what the people in our immediate vicinity were like in our childhoods, especially our parents. These formative figures determine a whole range of our behaviors. Our sense of, for example, how people might respond to our weaknesses, whether those in authority are benign or humiliating, whether setbacks can be met with panic or resilience, whether others can be depended upon, and so on. In other words, we don't enter adulthood like a blank slate, waiting until all the data is in before we judge a situation and draw our conclusions strictly on the evidence in front of us. Instead, we have powerful but hidden tendencies to prejudge according to patterns laid down by our personal histories. Some of this prejudgment might be sensible, but a lot of it can be very troublesome. We may get more panicked than is warranted. We may be so suspicious we don't give others a fair hearing. We may be so sure we're about to be attacked, we strike out preemptively. We may be so nervous, we fail. The key thing about transference is that we can't generally tell it's happening. We assume we're entirely reacting to the present, when in fact, our feelings are drawing energy from a source from long ago. That's why maturity deeply depends on getting to know one's tendencies to transference. To help us in the task, psychologists have devised a number of tests to tease out these transferences. One exercise involves asking someone to finish sentence stubs very quickly, without giving too much thought, thereby allowing the unconscious to reveal itself. For example, another classic transference exercise is the Rorschach test, devised in the 1930s by the psychologist Hermann Rorschach. By being shown an ambiguous image and asked to say what it was, Rorschach believed that we would naturally reveal some of our latent guiding fears, hopes, prejudices, and assumptions. The important point in any Rorschach test is that the image has no one true meaning. Different people merely see different things in it according to what their past predisposes them to imagine. To one individual with a rather kindly and forgiving conscience, this image could be seen as a sweet mask with eyes, floppy ears, a covering for the mouth, and wide flaps extending from the cheeks. Another, more traumatized by, say, a domineering father, might see it as a powerful figure viewed from below, with splayed feet, thick legs, heavy shoulders, and the head bent forward as if poised for attack. The goal of maturity in general, and psychotherapy in particular, is to help you to get on top of your transferences. That means seeing the ways in which our views of authority or sexuality or uncertainty have been distorted. The idea is ultimately to be released from the past's indiscriminate hold on the present and to reduce the scope of our personal histories to determine our futures. Once we overcome our transferences, we can be free to respond more reliably to the world as it is, rather than how it was. If you like our films, take a look at our shop, theschooloflife.com/shop. You'll find lots of.
So there it is, transference in a nutshell. And again, this just doesn't, we're not discussing transference in this aspect. We're talking on how it can negatively impact the relationship. We're talking where it comes from and how we can identify and work within it to promote growth. I think all of us probably took Psych 101. If we think back to it, the video triggered me a memory there, and schemas. Schemas, if you remember from Psych 101, they're kind of skits or ways we have learned typically situations play out. It's a learned behavior thing in our mind that kind of like chances are highly probable when these things happen, they are going to go this way. And transference is a part of that. You get when we're interacting with people, they're rooted in schemas, and that's where if a client is displaying it and you can identify it and it's like it leads to maladaptive, we can use it to teach new coping skills or expand their understanding of the way things are. Even like just because you had this relationship with someone close to you doesn't mean that all relationships play out that way, or maybe it's a specific area where just because there's some abandonment stuff from schemas in childhood, and just because a person didn't respond to your call or text right away doesn't necessarily mean they're abandoning you, kind of thing. And you get what I'm saying? So there can be some therapeutic value in transference, I would say, unless you're comfortable with it. Well, first off, you should get comfortable with it because there is some value, but if you're not, you should try to like avoid it the best you can. I mean, it's okay to point to it and maybe even set a boundary around it, like, you know, not firmly, but just like, it seems you bring in some of this. I just want to talk about that a little bit. And although it might seem remind you of your father or mother in some way, that's not really the case. This is a different relationship. And again, if you're not like feeling skilled enough, seek some supervision and education around it for the next time, but that's also okay. Beneficial transference can be helpful in therapy when identified and used appropriately to help patients work through past traumas. For example, a child who has been severely abused by a parent may undergo transference by perceiving the therapist as a parent. Because a child might expect this role to be negative or harmful, recovery of abuse could be possible when the therapist does not abuse the child. Alternatively, the therapist uses the child's transference to supply what his or her parent did not, a safe and accepted relationship. So that goes a little further into the benefits of transference. In this case, the therapist may endure strong feelings or anger from this patient, which can be helpful to patient because it allows him or her, it can be helpful, it allows her him or her to express feelings that he or she could not express in an abusive setting. So that means you got to have thick skin when that's going on. Expressing these feelings could provide the client a feeling of relief if they confronted their own parents. So if you're going to go that far with it and you kind of almost like a role play scenario where you are let the client say the things they couldn't say and you respond in a positive way, that would be what they're talking about there. But again, that might be to them cursing you out and saying things. So you got to keep a poker face and respect that feeling and understand it's a therapeutic intervention, nothing personal. Countertransference, and this is where the countertransference can become into a problem. Conversely, when the therapist transfers his or her own unconscious feelings to the patient during a therapy session, again, unconscious, like we might not even be aware it's happening initially, you know what I'm saying? But I think that those are those times that after session, be like, where did that come from? We need to unpack that and look at it. And determine if it's a problem. It is known as countertransference. Countertransference is also periodically used to find a situation where the therapist literally takes on the suffering of his patients. That's like too much compassion fatigue, too much empathy, like that's a form of countertransference. So while transference may be beneficial when identified by the clinician used appropriately as an intervention, when the clinician instead responds to the transference by adopting the projected role, and I gave a lot of examples of what I'm talking about with that, this will damage the therapeutic relation and potentially negatively impact the client. Countertransference in psychoanalytical theory. Countertransference occurs when the therapist projects their own unresolved conflicts onto the client. This could be in response to something the client has unearthed. Although many now believe it is inevitable, countertransference can be damaging if not appropriately. We're going to watch another video here in a minute. I don't remember if it's this one, but one coming up. There is a therapeutic element of countertransference, and it goes around universal countertransference. And I think the video only mentioned on it. So before we get into it, I don't want to cause any confusion. So universal countertransference would be the class clown or aggravating person is definitely transferring their interactions and settings and people, but it's not just you that sees that. You understand? Like the whole treatment team, people that had them in group, it's definitely that's still that role projection thing going on, but it's a universal observation and you're not emotionally involved or responding in a way. I mean, we might be, and we have to catch it still, and that's where the team comes in, and that's when there allows an opportunity for intervention. That could be the only positive one I think about. Any other form where you're taking on the role of a personal relationship and especially responding in a way, whether it be parental figure, whether it be the codependent dependent relationship, whatever that may be, then it's a problem. So actually, I don't think this is it. I think it's the next one, but we'll watch this one and then unpack a little bit.
I would define countertransference as those reactions that we have to patients that are based primarily in our own unresolved or partially resolved conflicts as a result of our own developmental histories, our own idiosyncratic reactions to patients that perhaps aren't widely shared by other therapists, that somehow there's some recognition that the work that we do with patients, and I think particularly with patients with personality disorders, inevitably is going to stir up some of our own issues, and all therapists have these reactions. It's not a function of being a trainee. There's no point in our careers where we become immune to these kinds of reactions. So the point is to understand that these reactions are going to be triggered within us, that they can get in the way of our work if we don't understand them, and that it's really important to try and pay attention not just to the client, but understanding what's going on internally and between the client and myself in the moment, which is a tall order. But in terms of countertransference, what am I feeling? What am I thinking? What's my body experiencing, sensing? And what am I actually doing with this client that raises some suspicion for me that perhaps my own issues are at play here? And can I use my understanding of my own, especially internal reactions, to facilitate the work? So, for example, if the client is provoking some sort of rage in me or anxiety in me, is this what might be called objective countertransference, where the reaction is typical and might be shared by one of my classmates who would be seeing the same client or the same type of patient, or is this reaction somehow a reflection on me because of my own developmental history? There's some way in which what the client is talking about, what the client is doing, what the client looks like reminds me of someone, including possibly myself, that causes me to react rather than respond. And in particular, if I find that I'm behaving or thinking or feeling in a way that's atypical for me, I don't usually react this way to clients, and I don't usually react this way to this client in my work with them. Then there's real grist for the therapeutic mill here. How can I try and reflect on those reactions in the moment, if possible, so that I don't act out defensively? And how do I reflect after the session on my reactions, either in supervision or with a classmate or on my own, in a way that my understanding might shed some light on the patient dynamics, on the relationship, and even on the course of treatment.
All right, countertransference. I think he summed it up nicely. Maybe done a little bit better job than me. I know I think the term is universal transference, universal countertransference, and he mentions in there, like, he used anger. I think that might even be better than the class clown example I gave. Like, we have abrasive clients sometimes, and if that frustration is just a common response to that client universally, then that's a point of intervention, even though they're still triggering that feeling inside of us, because that is the indicator, the feelings, the strong feelings. I mean, we have an element of what we do, even in evidence-based, where we're using our experience and impressions to guide us. So there is always an element of feeling. I'm talking about these intense feelings, whatever they may be, of pity, of like, of dislike. If we're having strong emotional ties to the client, chances are we have entered into this area. Oh, sorry, a little technical. Give me 1 second. There we go. Substance abuse individuals are regarded as one of the most difficult clients to treat due to the high level of behavioral problems, withdrawal symptoms, rude behavior, constant crisis, and challenges associated with the therapeutic relationship. Anybody taking this new to the field, it's okay. We're going to get through it. Anybody that's been with us a while, I don't think that anybody would negate that stance. And it's okay. They're still great people, and we love working with them. And I want to clarify that's usually early in the process. I know I've been doing this a long time, and early recovery is a lot different than when a person gets stable, and it's a completely different person. And that's kind of, you don't see the same stuff there. So there's a good side too, but early on, we're going to see this stuff. Some practitioners may even avoid substance use treatment altogether because of the level of difficulty and crisis associated with the addictive lifestyle. I like that a lot, because I know that if a client self-disclosure tries to ask history, I always say that no one said they wanted to be substance abuse counselors when they grew up. Like, we have a reason that we're here. Other people say, "Hell no, that's not for me." I have my own fields like with that. My oldest son is developmentally disabled, severely autistic. I probably would be great in that field because I've been fighting systems for him my whole life. However, I don't go there because I got enough of that in my own life. I don't want to deal with it. You know what I mean? Like, that would be hard for me. I'd be emotionally tied to that one a lot more. So I didn't go that direction. I went this way. I think that can go the other way too. Some people just know it. Whatever personal experiences they had with family members, things they've seen, they know it's a hard population. So while that might motivate some, others might say, no, I'm going to do mental health or work with development disabled. Many substance abuse persons entering treatment are in psychological and physiological crisis. Therefore, managing client crisis effectively is important to the success of the individual. So that goes into, if we are getting into emotional ties and these strong feelings, it's going to impact that negatively. We got to respond appropriately. Treatment for a client with such varying forms of behavioral problems as well as types of crisis can easily fuel a countertransference reaction. In turn, this countertransference response can ultimately affect the client's success. For instance, a therapist who reacts to be discharging a client wants to discharge a client from a program being rude behavior or be engaging in countertransference reactions to the client's behavior. Now, a lot of this I had put my own words. It's all come from somewhere, research, articles I found, things like that, things online. And I wanted to point that one out specifically because I feel I've seen that a lot and even done it early in my career. Like, it's not so much emotional. I'm a rule-oriented person for a reason. So if someone's breaking the rules, I feel there's consequence. And I still believe that, but like that knee jerk we're talking, I know in the embedded programs, this is a common response. And I used to work with staff a lot and still do, that it ain't about that. Those are behaviors. Those are things that we're here to treat. Those aren't reasons to throw someone out. I mean, outpatient, we don't even really discharge anymore unless they start closing. When I first started in the field, it was more common. But in the embedded programs, we still might have to, but typically that lies on a safety concern, safety to staff, safety to other clients. Those are the reasons we're discharging. That could be abusive, that could be verbally abusive, physically threatening, or a threat, or work in addiction. I'm thinking inpatient. I always gave the example. We catch a client coming in the door at admission and they got some drugs on them. We're going to work past that and it's expected. Clients been there a couple of weeks and somehow gets drugs put in, other clients get put at risk. That's a different thing. You know what I mean? So like, these are safety issues is why we would discharge in the only case. And again, that goes to embedded programs, but it is not uncommon for me to be in treatment teams or to work with staff. And just because something's going on, clients pissing them off, they don't like the way the client's acting, that's a form of it. And most of that we've worked on that level. We've talked about it. So, that's my feeling around it, but it is something we need to look at. Like, we are not going to throw anybody out because we're making you mad. And like, I'm joking there on that part of it from a supervisor stance, but from a clinician stance, I think you need to look at it. I think you need to remember that we're here to help this population. We're here to help these people. And back to the schemas, that's how some of that stuff displays is sadly the result of the interactions they have had with the world up to this point. And we're not going to change them overnight. And it's going to take time and it's progress. So we got to deal with those are the behaviors that we're going to see, especially in the better programs where it's magnified because they live there and we have to deal with them all day, every day. Just because they frustrate you or you don't like the way they talk to you doesn't mean you get to throw them out. Teasing a little bit, but it is something that happens, that not the throw out part, but that people talk about. So I think we need to be aware. If we find ourselves feeling that way, like, we shouldn't be discussing that and see how you feel or the client made you feel. We're in this area. Moreover, transference itself can be blamed for client outcomes rather than countertransference reactions behalf of a therapist. I like this one as well. For example, the therapist who blames the client for inappropriate reaction to treatment standards is an example of the therapist blaming transference rather than professional accommodating and treating the client for the behaviors for which they entered treatment. I think this one goes to more outpatient setting, inpatient and residential too, but outpatient clients not interacting. They're kind of like, they're not our favorite client. I mentioned early on in training, and we just want to throw our hands up and be like, it's their right to fail or whatever the case may be. Instead, though, we need to look at why we're personally involved with this, why we're taking any type of responsibility or blame. And instead of just throwing up our hands, why are we not sitting down as a team or self and thinking of interventions, how to engage the client? Because again, it goes back to my last slide where these are the behaviors common that we see in treatment that we got to deal with. The most extensive account of countertransference reactions among therapists is substance abuse was developed by WIS 94. WIS 94 accounts for several factors that cause countertransference among substance abuse professionals. These reactions based on client behavior as the fuel for the countertransference reaction and do not consider therapists induced countertransference. And we're going to watch another short video here, and then we're going to talk about that a little bit, and then what I just mentioned, the common issues, and then that will be it for today.
Good morning. It's Dr. Patricia Coughlin. At the request of a subscriber, I'm going to talk to you today about the phenomenon of countertransference and how important it is for us to practice what we preach. In other words, to be aware of our own feelings, anxieties, and defenses. Now, when these are unconscious, of course, it's very difficult to become aware of them. And this is why reviewing your own videotapes and being in supervision is so very important. I mean, we don't see what we don't see. We don't know what we don't know. But some of the time when our treatments are stuck or even break down, we're contributing to that in some way. About a year and a half ago, I was at a conference with Jonathan Shedler in Poland, and he was doing a workshop on supervision. And I was very pleased to see that we had a high level of agreement on what trainees usually bring to supervision. He said there are really two reasons why people get stuck. And obviously, when someone's bringing a case for supervision, it's because they're stuck in some way and they need help. And he said he finds that 80% of the time, it's because the therapist hasn't adequately understood or gotten agreement about what they are there to do, right? This agreement between the patient and therapist about the problems, the goals, and the tasks. And in the other 20% of the cases, he said it's some sort of countertransference. Davenlou said something very similar, that we can't assume that just because you're having trouble, it's a countertransference issue. Often it's a lack of knowledge and skill. But once that's addressed, if you're continuing to have problems, it most likely has something to do with you and your own emotional reaction to the patient. So what do we mean by countertransference? Classically, it refers to the therapist's transference to the patient. In other words, at some often unconscious level, the patient actually represents someone from the therapist's past life. And I have certainly seen this materialize in supervision, where, and often actually in supervision, there is an unconscious alliance between the supervisor and the therapist. And so I'll often hear, I was planning to show a particular case today, but for some reason I just decided at the last minute to show this case. And in every instance of that, it's because the therapist was having some kind of countertransference and really needed help with it. And we end up finding out that this patient really represents their very troubled acting out brother or whatever it might be. So that is a classic example of countertransference. But there are other definitions as well. So that is a specific countertransference, that this patient has a particular meaning to you and represents someone from your past toward whom you have a lot of mixed feelings. But we can also have what's called a universal countertransference. So sometimes in group supervision, a therapist is struggling with a patient. We can see that they're actually annoyed and impatient, and they're not very attuned. And I will turn to the group and ask, who's feeling irritated with this patient? And everybody raises their hand. That is a universal countertransference. It's something that the patient is inadvertently pulling for, and that probably other people outside, their friends and bosses and family members, are also experiencing. So why is this important? Because how you're going to deal with your countertransference has everything to do with understanding its source. So if the source is your own unresolved feelings about someone from the past, that's up to you to deal with. But if it's a universal countertransference, something that the patient is actually pulling for, then we want to use that certainly to inform us and perhaps in some way to learn to communicate to the patient. So I remember Davenlou talking about what he called metaphorical self-disclosure. So he wouldn't say, listen, I'm starting to get annoyed. This was in a case I had presented to him called the giggling college student. So this girl was giggling constantly and jumping from one topic to the other. And he suggested saying something like, this could be annoying. Do you ever find that people become irritated and impatient with you? So he was recognizing that anybody would have this reaction, and it's something that she's inadvertently pulling for. So those are two ways to, first of all, start defining countertransference. Is it a specific personal countertransference or a universal one? We can also look at it as conscious or unconscious. Sometimes consciously, we just don't like this person, or we find them incredibly boring and we're just like ready to fall asleep. So we're going to be able to work with that, right? Because we're aware of it. Try to understand again, what's the source of this? Of course, if it's unconscious, you're going to need help with that. And in most cases, you're not really going to be even aware that it's something in you. So taking those stuck cases to a supervisor is going to be really important. The other thing I wanted to talk about is whether the countertransference is positive or negative, right? Are you having negative feelings toward the person, or actually really positive feelings? You really like them, or maybe you're even attracted to them sexually or emotionally. So in that, sometimes we think, oh, it's only negative feelings that are a problem, but any countertransference, including a positive transference, is a distortion in the relationship and is a problem. So I had a trainee just last week who was open and honest enough to say, I realized that I actually like this person, and I want them to like me. And I realize it's in cases like that where I consider the patient kind of cool, and maybe they would be a friend of mine if they weren't in treatment with me. That's where I really get tripped up, that the trainee's desire to be liked by the patient, to be seen as cool, really is interfering with his ability to do his job. And that also could be, again, sort of one of your universal kinds of countertransferences. So instead of just getting triggered with certain patients, you might have a general tendency to want to be liked. And I see this with many, many trainees, that they have a big people pleaser dynamic going on. And this really interferes with them being able to say difficult things and have difficult conversations. So in other words, it might be sort of almost a character trait of yours to be excessively people pleasing and to want to be liked. And that really has to be addressed for you to become successful and effective. So obviously we are just skimming the surface here, but it's all in the way of saying that you being aware of your own impact on the patient and the process, and getting help when you're running into difficulties so that you can begin to see whether countertransference is an issue and then what you can do about it. So thanks for listening, and I hope to get lots of.
So I want to jump on what she said a little bit, because I think that I'm talking about this in a way like avoid it, be aware of it. There's levels, like with everything. And it's transference, countertransference. It's going to come into play. We're all going to experience it. The trick is to recognize it, be willing to talk about it, be willing to work through it. That doesn't mean, if I gave the example of the young man when I was working inpatient, that doesn't mean I can't work with that young man again. As long as I am self-aware that I had that reaction and was like, hey, that felt very familiar, or that's not typically how I respond to clients, or where did that come from? And looking at that level, man, he reminded me of my son when we were going through that thing, you know what I mean? And if I can get past that, and that's okay, it does not damage the alliance, does not damage the relationship. So again, it's not anytime that we see any little flash of it, we have to, oh, we can't work with the client. That's not what I'm saying there. I'm saying that's time to be self-aware and seek supervision or talk to your peers and be willing to listen. Like I said, I worked on that team in Dansville and we had a great team, and we would call each other on that. Like, hey, it seems you're a little too emotional about this. What's going on? Like, and we would talk it out, because I think we never really sat down and hashed all the details out, but I think that was just an experienced crew and they kind of understood that comes up. So we can talk about it openly. And I hope that's the kind of team you're on. If not, or just maybe it is and you're just not comfortable with them yet because you're kind of new, at least start looking for people you can, and your supervisor will always be a resource. We got some good leadership here at CASA, and I'm willing to bet anything any of them are willing to talk to you about this kind of stuff. All right, back to the presentation. We're almost through it today. This was a little bit longer one, I'm sorry, but there's a lot to go over. Anger is the most common reaction among treatment therapists' countertransference response, and this often leads to rejection of the client. The therapist can also experience some anxiety related to lack of control over the addict. And I mean, that alone is like, again, we're talking about early recovery stuff here. That is just irrational and thinking. If we think that we're going to control this, we can work through it, and it's going to take some time. But that frustration, you got to ask where it's coming from, because especially maybe you had that's countertransference might come that you had an addicted brother or addicted spouse that maybe is in recovery, but you remember what that's like. So it's triggering off these strong feelings. WIS 94 identifies several behaviors that fuel common countertransference, such as erratic attendance, concealing substance abuse, disregard for standards, grandiosity, repetition of speech, denial of illness, and continued drinking or substance use. Through displaying these behaviors, the client is exhibiting transference from previous enabling relationships. So I already talked about this a little bit. So just because, like, I always think of, even though that's my favorite cartoon as a kid and even still like it today, The Simpsons, and Homer Simpson is the dependent and Marge is the chief enabler. And yes, that we all love those characters, but if we look closely, that's what's going on there. And Homer kind of stays out all night, gets drunk, and Marge never really addresses with it. When they transfer that into a treatment setting and we're acting like Marge, that's the form of countertransference. I mean, I do not negate we work in a difficult field where we are trying to challenge and change difficult behaviors that often, especially early in the process, clients are not even ready to look at or change themselves. It can get frustrating, but that does not mean that we should either enable it and not hold account, be willing to talk about it, have those hard conversations. And that's what we're here to do. We're here to redirect, teach new stuff, and unpack where that comes from. We can't fall into the Marge Simpson role. Through ignoring it and hiding it, not reporting to mandators, the clinician exhibiting countertransference may be unconsciously playing the role of chief enabler. Countertransference can also lead to reactions among professionals. The substance abuse persons can ultimately result in countertransference hate, as well as an ambivalence toward the client. Ambivalent behavior or low motivation on behalf of the client can stimulate the therapist to react countertransference hate towards the client. That's the throwing the hands up thing and dreading and not even wanting to engage. And we need to look at that, because there should not be that personal connection there anyways for us to have those strong feelings. These types of reactions among professionals can significantly impact the therapeutic relationship if left unacknowledged or disregarded. I got one more video, and it's a short one, and then I got some common countertransference areas I'm just going to go over quickly, and then we will wrap this up. This is a good topic. It's one of my favorites, and it's one that I know is present. I've seen it. I've done it. Still happens. We all experience, and it's something that we don't ever talk about, and it can be so damaging that I think we need to. I think that what motivated me is when I was starting to put that together, and I came across that research article that said that success rates go from 13 to 60% when this type of training is given. I said we need this training because I see it all the time, and I'm sure if you guys want to be honest with self, we know we've done it, and at least we know we've seen it in our colleagues. And again, it's okay, nothing to be judgeful or shameful about. But it's one of those things. Let's get out in the open, work through it together as a team, and start giving the best services we can.
Hi, I'm Amanda Rowan, founder and head coach at the Therapist Development Center. If you're a first-time viewer and looking to pass your social work or MFT licensing exam, or just interested in topics relevant to clinical social work and psychotherapy, you've come to the right place. If you like it, be sure to subscribe for updates. You can also sign up for our complete LMSW, LCSW, and MFT exam prep programs by going to our website at therapistdevelopmentcenter.com or clicking on our logo. Today's topic, transference and countertransference. If you're preparing for your ASWB clinical social work exam, transference and countertransference are two topics you definitely want to familiarize yourself with. As a coach, I get a lot of questions on the difference between these two topics. Many social workers confuse the definitions of transference and countertransference and assume both warrant the same response. As we'll discuss throughout this blog, transference and countertransference require very different actions, both on the exam and in real life. What is transference? Transference is a dynamic that occurs in therapy between the client and the therapist. Transference is when the client redirects or transfers an unconscious feeling, desire, or expectation from another person toward their therapist. For example, a therapist may remind a client of her mother. Then, without the client even realizing it, She begins engaging with the therapist as she does her own mother. Transference can actually help the therapist identify patterns of relational interaction occurring in the client's life. Is transference a cause for concern? How should we respond to transference on the exam? When you see transference on the exam or in real life, don't panic. Transference is a common occurrence in therapy and is not cause for alarm. If you see a question on transference on the exam, you generally are not going to jump to anything drastic, like referring out to another therapist. Instead, you can actually use transference therapeutically. If a client is interacting with you as they interact with their mom or dad or spouse or child or coworker, you can use this as an opportunity to explore these relational dynamics and patterns in therapy. Because transference is about the client, it is not about us. It is okay to use it therapeutically. What is countertransference? So how does countertransference differ from transference? Countertransference is essentially the reverse of transference. In contrast to transference, which is about the client's emotional reaction to the therapist, countertransference can be defined as the therapist's emotional reaction to the client. Similarly to transference, countertransference is a common occurrence in therapy. Because of this, it is essential that we as therapists are aware of how countertransference may be showing up in therapy. We may observe countertransference occurring when we have a strong emotional reaction towards a client. One common example of countertransference is when a therapist finds herself feeling protective and parental towards a client, as that client may be reminding her of her own child or someone else she feels protective of in her life. Another example is when a client rubs you the wrong way. This may actually be you experiencing countertransference towards the client as they remind you of another person in your life who incites a similar emotional response. How should we respond to countertransference on the exam? It is important to know that on the exam, we are not going to respond to countertransference the same way we respond to transference. While we can use transference therapeutically with the client because it is about the client, we do not use countertransference in therapy. Countertransference is about us, the therapist, so we are not going to discuss it with the client. On the exam, the most common first action you will take in response to countertransference is seeking consultation or supervision. Seeking consultation or supervision allows you to work through your feelings of countertransference. This helps ensure our countertransference is dealt with appropriately and doesn't impact our client or the therapeutic relationship. Additionally, there may be times a therapist seeks their own therapy in response to countertransference issues that arise. The hope is that consultation and supervision and/or our own therapy will be enough to manage our countertransference. However, if both of these techniques are utilized and the therapist is still unable to manage their emotional reaction to the client, it may be necessary to refer the client to another therapist. Know that this is the last resort and not the first step we would take on an exam question. Finally, we are going to use the same LMSW.
She's going to go through some practice questions, and we're not going to do all that. I'm glad she said it because I wanted to emphasize on that, and I would have forgot. So I've talked about supervision, education, self-awareness being part of this. She says that it's not something we talk about with the clients, and that is true. Countertransference is not something we say to the client or discuss with the client at all. That's what we seek supervision or talk to our colleagues and peers about to work through. And the reason being, and again, because even if we're doing that, then we're making it about us. I mean, what are we going to do? Go to the client and be like, hey, we need to talk about this thing because you make me feel like I'm working with my brother here. Like, that's not the client's problem. That's our problem. So again, we don't discuss this part with word transference. If we identify and work through it, we can unpack and work for the benefit of the client. If we're going to discuss how they're causing us to counter transfer some of our stuff with them, sorry about that, then that's a problem. We seek supervision or talk to peers and colleagues, both preferably, if able. So countertransference items. Similar to the boundaries crossings, I first want to say we are human beings and we all make mistakes. So on occasion, if this happens, I'm not saying that you freak out and like, oh my God, I can't work with this client. I mean, you can talk to supervision about it. We're talking about in your regular practice, if it's common, or to specific to like, maybe it's not common. Then all of a sudden one client specifically is bringing all this up. You know, I mean, that's when it becomes an issue in the area we need to work on. So obviously we can't get feedback, so I'll just go through them real quick. Rejects the client in session, shuts the client down, like just don't want nothing to do with them. Treats the client in a punitive manner during session. This one I think is very important because I know it's very common when I see, like, I am big about collaborative care and I am big about working with mandators, but I'm also big about, I set that pace from the door. I set it from the first session. I make it like the client knows that's my job. They know what they're, even though treatment is separate, that they are being mandated and that has to be reported to whoever's mandating that. And again, not all clients are mandators. This could go with family or anybody else. I'm going to give positive, I'm going to give negatives. I'm going to tell when the client's doing great, and I'm going to tell when the client's maybe having some issues and like what we're doing about it. Because my goal is to, I mean, by doing that, that's another thing too in this transference, transference. If we're protecting and hiding from the client, I mean, the legal mandators know that it is common that our clients can be manipulative and that our counselors can be emotional. So therefore, if they get the sense the client is in that situation and you are hiding, uncovering, they're much quicker to yank that chain. And I want to avoid my clients going to jail because I believe jail is not any place for human beings. So that's another reason I work collaborative, because once I establish and that person knows I'm on the up and up, even if we have a fallback, which is very common, and I say, hey, we're working through this, they're going to go to some extra groups this for the next few weeks, or maybe it's to a level they got to go to inpatient, this place is going to accept that, and the client's not going to receive negative consequences due to what really is a treatment issue. So how on the flip side of that, though, I have seen it very common where maybe a counselor does not work in the way I work. And hey, each his own, even though I think that's the wrong way, like whatever, if it's working and it's not causing harm, I'm for it, if that makes sense to you. However, then that client does something that really pisses that counselor off and they just call their parole officer right up or treatment court right up and be like, this person needs to go to jail, da, da, da. You are acting in a punitive manner. And that's the thing that we need to avoid. So again, very important to work collaboratively, not so much to be a jerk about it and try to punish a client or cause negative consequences. I mean, I am big on motivational interviewing, and that is like kind of, there's a part of that is recognizing the client's learning opportunity to run into that wall so they can grow from it and then reflect. Like that's a strategy for counseling, and I'm for that. You heard me? There's a lot different than, we are not supposed to intentionally be the cause of negative consequences in a client's life. Do you get that little difference there? You understand the client causes their own negative consequences. That's a different thing. You know what I mean? Even if we know what's going to happen when we report, the client still caused that. We didn't cause that. Client runs out of rope and the client has to face whatever they were facing because they didn't do what they were supposed to do. We didn't cause that. You know what I mean? However, if we are intentionally trying to emphasize, or again, maybe it's been ongoing, but we were kind of avoidant before, and then all of a sudden we want to yank that chain, so we give this intense report, we cause that harm. You know what I'm saying? And that's the difference right there. Engages in too much self-disclosure. Talked about that a lot already. Expresses hostility toward or about a client. That one's a big one. That one too, like it happens. Sometimes we have emotional response too. Once in a blue moon, it is what it is. If this is a normal, or if one client particularly is bringing this out of us, then, I mean, even the other stuff is transference, countertransference, but that's when we caught it and handled it appropriately and worked through it. This is if we're ongoing and not seeing it, and maybe a colleague pulls us up or we have noticed it, then we need to start working on that. Acts in a submissive way with the client during session. So if the client's running the show, the client's telling you what it is, and again, we're person-centered, so we want to be person-centered. Doesn't mean the client completely dictates. It's a collaborative effort. So like, if we're allowing the client to dictate that treatment and it's good, that's person-centered. If we're allowing the client to dictate that treatment and we know it's going to lead to negative consequences or harm in their life, that's what they're talking about, the submissive thing. Or if we're just nervous and afraid and whatever the case may be, I mean, we're humans too, and maybe we are in a violent relationship and things this client does makes us trigger some feelings in that, so we can't respond to them as we should. Even that, the client isn't even aware. They're just being themselves, but the way their hand movements, their tones of voice, the things they say, maybe they're triggering us. So that's impacting the relationship. That's something we need to see supervision for. Is over responsible for a client. Blame self. Oh, it's all my fault. I wish I could have done more. Da, 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 da. You know what I mean? And again, we have some ethical responsibility. If we're doing our job, that is not the case. We are not responsible for the client. You know what I mean? If there's something that we know that we can improve on in practice that will help the client, we're not doing it, that's a different thing. You know what I mean? We'll start doing that though. You know, maybe we didn't think about it yet. Don't beat yourself up. Dread seeing a client during a session. So, oh my God, it's Wednesday and I see this client on Wednesday and I hate him. Yeah, we need to start seeking supervision for that. Befriends the client in session. So that's that overly like wanting to be your friend, wanting to be liked, have an emotional response. Feels protective of a client. We've talked about that in boundaries and in the countertransference area. If we were covering up enabling, taking up the role of that has been projected on us of the codependent chief enabler person, the countertransference is us respond to that. That is when we are experiencing that one. Defends a client in supervision or in team, same thing. Express feelings of guilt to a client, significant discrepancy between case notes and what actually occurred in session. And I know this can be a tough one because like we just want to show we're doing a good job and try to highlight the progress that clients have made. And that's okay. I think that's okay when there's progress, even if there is a negative to include. But as far as like totally ignoring or not reporting, maybe the client flipped the hell out during session and you don't even mention your note, you might want to ask yourself why you felt the need to hide or protect that. Express feelings of envy to a client, does not bring up client supervision or team, express a need to be respected, appreciated, and loved by the client. That's not, we don't get them feelings from them. Acts defensive in supervision, expresses demands to help a client. And again, there's a fine line. I know like in inpatient and residential and the bedded programs, that can really be a thing. There is a line between advocacy and a line between like you're wanting to be the hero and you want to be the one to make all the dreams come true kind of thing. And that is where that comes into play. I mean, please believe me, if working with a client and I'm trying to get them a bed at an inpatient or from inpatient to a residential, I will knock down doors if that's what's needed to be done, because I know the people on the other end are human beings too, and they're busy. And I'm not trying to be like an a-hole about it, but like, I know we get sidetracked, we get busy, we forget things. So I'm going to get that done and I'm going to like advocate for my client. That's a lot different when I'm demanding the client gets an extra piece of cake and throwing myself, or and I'm obviously talking about the bedded program, or I'm demanding that a client doesn't get reported. I've seen this on both sides. Like I've seen it on administrative level. Maybe a client has a positive urine and one of the people involved in the situation is adamantly defending their claim that they ate something, someone put cocaine in their drink and they were fighting for the client. And you can report that the client reports that the client, someone put in a drink to the PO and let them determine that. But again, to adamantly like fight for that, it is our duty. We have a positive screen that we have the evidence to suggest. I mean, we can like side with the client all we want, and we can acknowledge the possibility. I personally believe cocaine's expensive and no one's going to put it in anybody's drink for free. But I'm saying, if we want to, like, if there's a case or there's situations that might warrant it, and maybe it's a vindictive relationship in the spot, and like, if there's really like something there, you still got to report that. And if you're like willing to throw a fit and get angry and make demands, then that could be something that is going, something else is going on there. Avoid eye contact in session, rushes to solve the client's problem, cherishes one specific client, departs from typical therapeutic style. So again, if we have our norms on how we react, and this one person makes us go outside of that, we need to look at that. Behaves as he or she were somewhere else during the session, is apathetic toward a client in session, I would like just shut off and not responsive and whatever. Feels hurt by something a client says or does in session. These are all common countertransference areas. These are only a few examples of countertransference responses. There are so many types of countertransference reactions among professionals, it's difficult to identify every type of countertransference reaction. In addition to the therapist countertransference, the substance abuse treatment field includes a large amount of social stigma. Even those who are therapists in the substance abuse field may be subject to professional stigma. And I know that I've experienced this as well on some cases. It's not the norm, and I think we've come a long way with it, but like there are just these people like, oh, you help them or you work with them, you know what I mean? And come on, and it ain't gonna affect me, but I wanted to include this in this training because I could see how for some it would. Meaning that those who are working in the substance abuse treatment field may be looked down upon because they're treating someone of society's most disliked people. Ultimately, the negative perception can be projected onto agencies as a result. Some programs may be underfunded, for instance. Larger organizations do not invest emotionally and financially in substance abuse programs within their organization. This projection is considered an example of ways that agencies in general can subject to countertransference reaction. And when I was putting this together, I thought about the extreme pushback that we had from the community at a large when we wanted to open the residential program in Dansville. And there was a lot of people in uproar and they didn't want it there. And I think, although we worked through that and kind of just our leadership team just pushed right through that, like this is happening, and did as much community work and raise awareness as we could. I think that is a good example of what that is. I mean, because the people don't even know what's going to happen. And they're all up in arms, ready to throw up, and all this like negative things are going to happen because this population of society's stigmatized people were moving into their backyard. The therapist's response to countertransference. Countertransference reaction toward a client can vary from positive, loving feelings to anger and disdain. Additionally, these countertransference reactions can cause transference responses in the client, which can also have a varying impact of client behavior. The characteristics of a therapist that allows therapists to manage countertransference reactions appropriately include skill management of anxiety, level of empathy insight about one's own personal conflicts, skills in conceptualizing client dynamics, and high personal integration. The therapist's response to countertransference. The counselor's education or skill in managing countertransference may interfere with success. Like if we're not even aware of it as a thing or that we're doing it, that can definitely have an impact because we're completely unconscious. As a result, the counselor may blame patients for failing to thrive in treatment rather than the counselor seeking supervision regarding a countertransference response. As these characteristics increase the likelihood of therapists having the knowledge and skill to manage countertransference reaction, it is therefore important to ensure the substance abuse therapeutic community is educated on countertransference. And I sincerely hope that is what I did today. Because like I said, it's common. We've all been through it. I've experienced it. I've worked through it myself. I've sought supervision for it. I've helped other staff experience in it. I told you I worked on that team that we were very good. We're a strong, cohesive team, and it takes time. It's a thing, and we can't be ashamed to talk about it, and we can't be ashamed to be self-aware and that we have feelings too. You know, what the shame would come if we don't address it, and then it crosses over into other things that negatively harm the client. Or, I mean, again, if we're talking about transference, countertransference, and a spousal romantic relationship, then that also is how. Again, I said that transference, countertransference is a separate thing but can relate boundaries. That's an example of how it can relate to the boundary violations. Because if we get stuck in that and we go down that road, how far can that go? And then we're into ethical boundary violations, possible sexual misconduct, staff exclusion. So in my life and working with clients, I believe the best offense is a good defense. Is that how that saying goes? I'm not quite sure, but I think you get the gist of what I'm saying, that if we get in front of it and we can own it and we can look at it and be comfortable in it, we can avoid so much. If we don't open the doors and we don't start down a path, it's just easier that way. And that's how this all ties into boundaries, and it can all be related. But either way, I am hoping that research is correct. Now, I don't think any of us are down 13% in the number of programs, but that significant increase in success of clients, that is the goal of this training, and also hopefully to help any of you who might have been struggling and had questions. If you have any further questions, feel free to email me, dcrawford@castatrinity.org. I know you'll find me in the address book, and that's all I got today. Have a good one.